Mr. Stomach can be defined as the most distensible part of the GIT. But if you take too much stress, it is a victim of acidity. So please don't take too much stress. You need to go easy on yourselves. All the best for the abdomen series. Oh, all the best. Hello. I hope you guys had fun with the spleen, and now we move on to the stomach. Now I want to mention right here that whenever you think of the stomach, we always perceive it in a two-dimensional shape. But if you observe carefully in this three-dimensional figure, you'll see that the long axis of the stomach is not vertical. It goes forwards and downwards and from the left to the right towards the midline, and by the time you reach the pyloric end, it starts going backwards and upwards again and more towards the right to meet the duodenum, which is a retroperitoneal organ. The stomach, however, does enjoy mobility except at its upper and lower ends. Let's try to find out some more things about it. Now we've already discussed the proforma of an abdominal organ, so I'm not going to go through it, but just take a few seconds and understand what all we shall be discussing it under. So, it comes from the Greek word gaster or the Latin word venter. Most of the adjectives such as gastric carcinoma, gastric acid, gastric canal, all these come from the Greek word gaster. The stomach can be defined as the most distensible part of the alimentary canal. That's an important definition. Please use it. The stomach functions mostly as a reservoir of food. There's not a lot of digestion that takes place in the stomach. The only things that are absorbed through the stomach wall are water, salts, a typical class of drugs known as NSAIDs, which can commonly be known as painkillers. And what the stomach essentially does is mixes the food inside it into a semi-solid mass known as chyme. CHYME. However, what's really important about the stomach is the presence of special cells known as parietal cells that secrete the hydrochloric acid. Hydrochloric acid is important for breaking down the complex molecules into simpler versions, and it also acts as an antibacterial and disinfectant chemical. Finally, the parietal cells also secrete the intrinsic factor of Castle, which is a very important element in the absorption of vitamin B12, which happens in the ileum. These are the most important functions that you need to remember of the stomach. Also, the pyloric sphincter at the distal end of the stomach acts as a regulator that controls the delivery of chyme into the small intestine for further digestion. Location and extent. The stomach extends into the left hypochondriac, the epigastric, and the umbilical regions. The two ends of the stomach, which are the upper cardiac end and the pyloric end, will be discussed in the next slide. Do remember that most of the stomach lies under cover of the left costal margin and the left lower ribs, roughly 7th to 10th. Shape. The stomach is J-shaped. That's the most common variation that you will see. A more vertical might look reverse L-shaped. Then you also have the semilunar variety, which might look like a half moon. Sometimes it might get even more flat than that, which gives it a characteristic steer horn shape, which is mostly seen in short, obese people. In tall and weak people, the stomach might present with a more long, low, and elongated shape. Do remember that the stomach shape varies even in the same individual depending on variable factors such as whether he's upright or supine, whether he's just eaten food or not, whether he's fasting, etc. etc. So the shape of the stomach even within the same individual is inconsistent. That's exactly what we say in the definition. It's the most distensible organ and thus offers a high amount of flexibility. At birth, the capacity of the stomach is 30 ml. At puberty, it's about 1 liters, while in adults, it may extend from 1.5 to 2 liters. Again, you might notice that when you start dieting and reduce your food intake, your stomach literally starts getting smaller in size, which is why you don't eat as much as you used to once you start your diet. Similarly, if you are on a weight gain and you start eating more, eventually the stomach starts getting more distensible and you can thus accommodate more food, and your appetite seems to be increasing as well as your capacity to eat more. Measurements: the length of the stomach from the cardiac to the pyloric end is 25 centimeters. Let's see how that can further be divided. The stomach can further be divided into the fundus, the body, the pyloric antrum, the pyloric canal. Let's see how it is divided as such. First, we'll discuss the ends of the stomach. It has two ends, the cardiac end and the pyloric end. It has two surfaces, the anterior-superior surface and the posterior-inferior surface that lies behind. It has two curvatures, the greater curvature and the lesser curvature. It also has two notches, the cardiac notch that is present here where the esophagus meets the greater curvature, and the angular notch or the incisura angularis where the lesser curvature shows the most dependent area. Everything that lies to the right side of the angular notch is a part of the pylorus, while everything that lies to the left is a part of the body. Now that's exactly what we use to divide the stomach into its subdivisions. If we draw a horizontal line from the cardiac notch, everything that lies above it is the fundus. If we draw a line that goes downwards and to the left side from the angular notch in such a way that it meets at a point roughly 15 centimeters distal to the cardiac notch along the greater curvature, everything that lies to its left side is the body. Moving on, what lies to the right of this line is the pylorus, which can further be divided into a more distensible pyloric antrum and the smaller and the much narrower pyloric canal. Totally, the length of the pylorus is 10 centimeters. So the fundus in the body contributes to 15 centimeters, and then another 7.5 centimeters contributed by the pyloric antrum, and the next 2.5 centimeters by the pyloric canal, thus making the total length of the pylorus 10 centimeters. Do remember that there is a sulcus known as the sulcus intermedius, which divides this pylorus into the much dilated antrum and the narrower canal. Eventually, the pyloric canal continues into the first part of the duodenum. Let's talk a little bit more about the ends. The cardiac end is basically the lower end of the esophagus joining to the cardiac part of the stomach. The opening is known as the cardiac orifice. It is sometimes important to understand more about its exact location from the point of view of surgery. So remember, it lies 2.5 centimeters to the left side of the midsternal line along the horizontal plane that passes anteriorly through the seventh costal cartilage and posteriorly through the level of the lower border of T11 vertebra. I'm going to say that again. The cardiac end lies 2.5 centimeters to the left of the midsternal line on a horizontal plane which passes anteriorly through the left seventh costal cartilage and posteriorly through the lower border of T11 vertebra. Another important thing that you can use to remember, especially when you're considering gastroscopy, is that it lies 40 centimeters distal to the upper incisor teeth. So when you enter the oral cavity with a gastroscope, the upper incisor teeth acts as a great marking which can be used to guide you towards the cardiac orifice of the stomach. Let's talk a little bit about the pyloric end. The pyloric end is where the pyloric canal connects with the first part of the duodenum. It lies about 1.25 centimeters to the right of the midsternal line at a horizontal plane that goes through the lower border of the L1 vertebra. If you remember the first lecture, this is known as the transpyloric plane, and that is exactly how it derives its name, because the pylorus is present at that level. A very important thing to notice about the pylorus is that the inner aspect of the pylorus shows a thickening of the circular muscle cord forming the pyloric sphincter. This is an anatomical sphincter as opposed to a physiological sphincter that is present at the cardiac end. When I say physiological, I mean there is no anatomical specification or variation that is seen in this area to make it look like a sphincter, but barometric studies definitely suggest pressure changes along this orifice, thus forming a physiological sphincter. Let us talk about the curvatures. The lesser curvature is shorter and it forms the right border of the stomach, and the most dependent part of this curvature forms what is known as the angular notch, also known as the incisura angularis. Okay? Also remember, it provides attachment to a double fold of the peritoneum that is known as the lesser omentum. Don't worry about the details of that. The greater curvature is forming the convex longer left border of the stomach. It presents a cardiac notch at its proximal most area, and please remember that it provides attachment respectively to the gastrophrenic ligament, the gastrosplenic ligament, and the greater omentum, details of which shall be revealed in subsequent lectures. I also want to just highlight a point that the highest point of the gastric fundus lies roughly at the level of the fifth intercostal space. We already spoke about the notches. The surfaces will be discussed with respect to what is related to them when we enter the 3D lab. But first, let's talk about the internal features. Now, I don't want to discuss them in detail because that would kind of come in histology. But if you go from within outwards, that is, if you go from within the lumen of the stomach and try to come outwards, the first layer that you will see is the mucosa, and the mucosa is studded with little pits that are known as gastric pits. These are actually openings that lead to the gastric glands, which is a histology topic, so we won't be discussed here. You have vertical folds. The mucosa is thrown into vertical folds, which are known as gastric rugae. A picture of that will be shown later. The lesser curvature, when viewed from the inside, forms a canal which is known as the Magenstrasse or the gastric canal. The layer below the mucosa is the submucosa, which we won't discuss in detail, and outside of the submucosa you have the muscularis, which is further divided into three layers. The innermost oblique muscle layer, which you can see over here, it is this oblique muscle layer that eventually, when contracted, forms a pinch that leads to the formation of the gastric canal along the lesser curvature. This is the canal through which liquids usually tend to travel directly from the esophageal to the pyloric end. This is also the reason why they are the most susceptible to damage by toxic fluids such as alcohol. Then you have the internal layer, which is the circular layer, and then the external longitudinal layer, which will be continuous with the longitudinal layer of the duodenum. Take note that the inner circular layer at the pyloric end forms a thickening to form the anatomical pyloric sphincter. Finally, the outermost layer is the serosa. Now, before we discuss the relations, let's go to the 3D lab and get a rough idea about how everything is oriented. Hello and welcome to the 3D lab. Now, today we're going to be discussing the stomach. I want to start from the anterior approach. So, the anterior relations of the stomach, and let's try to go from proximal to the stomach to the distal. First, on the upper aspect, closely related to the fundus, we have the left lobe of the liver. Just outside of that we have the diaphragm, which we can't see here, and then we have the rib cage. If you want to be more precise, you must also mention the pleura and the lower aspect of the left lung. So I'm just going to go ahead and add that as well. Okay. Finally, we obviously have the anterior abdominal wall. Now, since we are discussing the anterior relations of the stomach, I want to take this opportunity to talk about something known as the Trobbe's space. The Trobbe's space is an anatomical landmark which sounds tympanic on percussion. Okay, I'm just going to highlight the spleen here. Okay, now I've highlighted the spleen. Let's see what exactly are the borders of the Trobbe's space. So we have the lower margin of the left lobe of the liver on the right side, the lower margin of the left lung as the upper border, the lateral aspect of the spleen on the left side, and the lower margin of the left side of the rib cage or the left subcostal margin as the inferior border. What I just drew with the red outline is the Trobbe's space, a space that sounds tympanic on percussion, and it is clinically important because it overlies the fundus of the stomach, and usually the fundus of the stomach is air, which is responsible for the tympanic note. If there is pleural effusion or if there is splenomegaly, the character of this note will obviously change because of the presence of fluid in the case of the former and the enlargement of the spleen in the case of the latter. So just remember this as an important point. So to summarize, the anterior relations include the left lobe of the liver, the diaphragm, the pleura of the left lung, the lower aspect of the left lung, and of course the anterior abdominal wall, and the 7th, 8th, 9th, 10th ribs of the left side along with the intervening intercostal spaces. Now let's have a look at the posterior aspect of the stomach, which is also known as the stomach bed. For that, I'm first going to go and add the kidneys to the system. Great, now that we've got the kidneys, let's have a look. The best way to understand the stomach bed is by making the stomach disappear. Once you have a rough idea of where exactly it lies, let's hide it. Let's zoom in. Starting from left to right, you have the spleen, then the left kidney, the left suprarenal, the pancreas, the transverse mesocolon that essentially connects the anterior border of the pancreas to the transverse colon. So if I were to draw it, it would look something like this. And this is situated at the posterior aspect of the stomach. Finally, we also have the splenic artery, characterized by its highly tortuous appearance, and of course the posterior aspect of the diaphragm. So to summarize the relations of the stomach bed, we have the spleen, the left kidney, the left suprarenal, the splenic artery, the pancreas, the transverse mesocolon connecting the anterior border of the pancreas to the transverse colon, and a part of the transverse colon itself, mainly including the splenic flexure of the transverse colon. Let's go back to the presentation. Okay, so now let's quickly revise the visceral relations again. Related to the anterosuperior surface, you have the left lobe of the liver, the diaphragm, and the left side of the rib cage, precisely the 7th, 8th, 9th, and 10th ribs, along with the intercostal spaces. You might want to add the pleura and the left lung, rather the undersurface of the left lung. And then you have the anterior abdominal wall. In the posterior inferior surface, you have the diaphragm, the spleen and the splenic artery, the left kidney and the left suprarenal gland, the splenic flexure of colon and the transverse mesocolon, and the pancreas. I just wanted to mention here, and we can go into detail later about that in some other lecture, that all the posterior relations of the stomach, or rather all the structures of the stomach bed, are separated from the posterior inferior surface of the stomach by the lesser sac, except the spleen, that is separated by the greater sac. Now, what did I just say? Don't worry about it, but remember it. We'll revisit this in the lecture on peritoneum, okay? Meanwhile, the peritoneal relations, which I just want you to mug up for now, are the gastrosplenic ligament that connects the stomach to the spleen, the gastrophrenic ligament that connects the stomach to the left crus of the diaphragm, the greater omentum related to the greater curvature of the stomach, and the lesser omentum related to the lesser curvature of the stomach. Okay? Now, here's a picture. You might want to take a screenshot of this. This is from the 40th edition of Gray's. It's essentially the structures of the stomach bed, and you can see that the stomach has been faded. So you see exactly how the structures in the stomach bed are oriented. Okay, let's move on. Just a better view of the interior of the stomach once again. Observe the gastric rugae. Do remember that these are temporary and they disappear once the stomach distends, as opposed to the folds in the small intestine, which are known as the plicae circularis, which are permanent. Okay, note the circular thickening of the pyloric sphincter over here before we head on to the first part of the duodenum. This is a magnified view of the same thickening of the circular muscle coat, okay? And also you can observe the longitudinal folds of the Magen stress here. Here you can see the longitudinal coat, then the circular coat, and the innermost coat was already shown in the previous slide. That consists of the oblique muscle fibers. Now the vascularization. Just understand that the stomach develops from the foregut, And if you have seen the first introductory lecture, remember I spoke about the ventral branches of the dorsal aorta? Well, there's three of them, and the uppermost ventral branch is known as the celiac trunk. Since the stomach develops from the foregut, all the arteries supplying the stomach are essentially derived from the artery of the foregut, that is the celiac trunk. There you go. Now you can see that the left gastric artery is a branch directly coming from the celiac trunk. So is the tortuous splenic artery, another direct branch from the celiac trunk. This gives short branches known as the short gastric arteries, which supply mostly the fundus. Then we have the right gastric artery, and the right gastric artery usually arises either from the common hepatic artery or the hepatic artery proper. This is the common hepatic artery, and this is the hepatic artery proper. And the other artery that's going down is known as the gastroduodenal artery. Now that is what gives rise to the right gastroepiploic artery. Okay, remember it's a branch of the gastroduodenal artery. And the splenic artery also gives rise to the left gastroepiploic artery. The word epiploic essentially comes from epiploic foramen, a topic for another day. So to quickly summarize, the stomach is supplied by the left gastric artery, a direct branch of the celiac trunk, the right gastric artery, a branch arising either from the hepatic artery proper or the common hepatic artery. Both of these end up supplying the area of the lesser curvature. Along the greater curvature, we have the right gastroepiploic artery, branch of the gastroduodenal artery, and the left gastroepiploic artery, branch of the splenic artery. Finally, the area of the fundus is supplied by short gastric arteries, which are a branch of the splenic artery. Moving on to the venous drainage. Now, there's a slight difference here. The left as well as the right gastric veins both are direct tributaries emptying into the portal vein. The right gastroepiploic vein drains into the superior mesenteric vein. So you can't see it here, but you could probably see it here. See? This is the right gastroepiploic vein, and it eventually empties into the superior mesenteric vein. Note that the superior mesenteric vein as well as the splenic vein meet at the back of the neck of the pancreas to form the portal vein. More on that later. The left gastroepiploic vein drains, as you can see, into the splenic vein, and so do the short gastric veins. So you can see that the veins have the same name as the arteries, but they drain slightly differently. Chiefly, the right gastroepiploic vein drains into the superior mesenteric vein. Another important thing to note is this vein over here. This is known as the pre-pyloric vein of Mayo. Kindly note the pre-pyloric vein of Mayo, which does not have a corresponding artery, proves to be of great importance during surgery to identify the pylorus on the operation table. Okay? Remember, the pre-pyloric vein proves to be an important landmark during surgery to identify the pyloric end of the stomach. Now, the lymphatic drainage of stomach is vastly studied, especially by oncologists and oncosurgeons, because gastric carcinoma commonly spreads through the lymphatic route. I don't want to get into too much detail, but I want you to know that it is divided into 4 zones. How do we obtain them? Well, we draw a vertical line along the long axis of the stomach that will divide it into a right 2/3 and a left 1/3. Here it's more along the midline, but ideally it should be the right 2/3 and the left 1/3. Then the upper portion can further be divided into a right 1/3 and a left 2/3, while the lower portion can be divided into a left 1/3 and a right 2/3. Just draw it along and you will automatically never forget it. Okay? So, this gives rise to 4 areas or 4 zones. This quadrant is area 1. The one right below it is area 2. This is area 3, going more towards the pancreas and the spleen. And this is area 4. That's going towards the hepatic nodes. Okay, I understand it's slightly confusing because neither is it going clockwise, neither is it going anti-clockwise, but just remember, area 1, which drains into the left gastric nodes, which are along the lesser momentum. Area 2, which are the most important ones when it comes to the spread of cancer, drain into the right gastroepiploic nodes, which are present along the right gastroepiploic vessels, which you saw previously. And they also empty further towards the midline in the pyloric or the subpyloric nodes, which will be present in this area. Area 3 will go towards the spleen and the pancreatic tail, and these are commonly known as the pancreatico-splenic nodes. And area number 4 will go towards the, see the liver is present here, right? So it will go towards the hepatic nodes. And all of these ultimately drain into the celiac lymph nodes. Okay, you might want to take a moment and understand this better. Drawing a diagram would definitely help. This is the atlas picture. So these are the left gastric nodes. These are the pancreatico-splenic nodes. That's area number 3. These are the right gastroepiploic and subpyloric nodes, area number 2. And these are the hepatic nodes, area number 4. And all of these eventually go to the celiac nodes. Okay. Now, innervation. Whenever you're studying the innervation of an organ, the first thing you need to know is that it's going to be autonomic innervation, correct? That can further be divided into sympathetic and parasympathetic. Please note that in case of most viscera, sympathetic is motor to the sphincters, vasomotor, that is leads to constriction of the blood vessels, and carries the pain sensations. Okay? So, the sympathetic system would be motor to the pyloric sphincter, which means that the pyloric sphincter will contract, which means that the gastric emptying will be halted or delayed. What is gastric emptying? Contents of the stomach being poured further into the duodenum. So that is going to be blocked or slowed down. Okay? Motor to sphincter leads to constriction of sphincter, delays gastric emptying. The sympathetic nerves are derived from T6 to T10 spinal segments and travel via the greater splanchnic nerves and the celiac plexus. Just remember that much for now. T6 to T10 spinal segments. On the contrary, the parasympathetic system is motor to gastric musculature, which means that it leads to gastric emptying. So other than the pyloric sphincter, the remaining part of the muscles are contracted. That is, peristalsis is propagated so that gastric emptying is accelerated by the parasympathetic or the vagal stimulation. And the other thing is that these are secretomotor in nature, which means that the hydrochloric acid that is secreted by the parietal cells of the stomach, well, the vagal stimulation or the parasympathetic stimulation leads to secretion of that hydrochloric acid, which kind of should give you a clue that, oh, if we stop the vagal stimulation, then the acid secretion would reduce. And hey, who would that benefit? A person having acidity. Whoa! That's not rocket science. Anyway, the nerves obviously are the left and the right vagus nerve. So just remember for now, won't go into too much detail, but during the embryological life, the developing stomach rotates clockwise by 90 degrees, because of which the left vagus ends up giving the anterior vagal trunk and the right vagus gives the posterior vagal trunk. I hope you can imagine what will happen when there is a 90 degrees clockwise rotation. Left becomes anterior, and that gives the hepatic branch to the liver, the celiac branch, and the anterior nerve of Latarjet, also known as the greater anterior gastric nerve. Okay, remember this, the anterior nerve of Latarjet along the lesser curvature. Similarly, the posterior vagal trunk, which is essentially given off by the right vagus, also gives celiac branches. The posterior nerve of Latarjet, also known as the greater posterior gastric nerve, and the nerve of Grassi, which is usually just nerve branches going towards the fundus from the posterior aspect. Okay, the nerve of Grassi. The anterior gastric nerves also are very similar but go from the anterior aspect and supply the fundus, and these are the branches of the anterior vagal trunk. So once again, you have the left and the right vagus. The left vagus forms the anterior vagal trunk and gives off hepatic, celiac branches and anterior nerve of Latarjet along the lesser curvature, while it also gives some anterior gastric nerves to supply the fundus. The posterior vagal trunk, which is given off by the right vagus, gives off similar celiac branches, the posterior nerve of Latarjet along the lesser curvature, and the nerve of Grassi, which ends up supplying the fundus posteriorly. Take some time and get this inside your head. Now, I don't like to discuss a lot of clinical anatomy since this series deals with the gross anatomy only. But we've already considered Trobbe's space. You might want to try to draw that so it gets better imprinted in your brains. Gastric carcinoma, very important. The fact that it is spread by the lymphatic route is why you need to know your lymph zones very nicely. Please remember this as an MCQ, that the Virchow's nodes are the left supraclavicular lymph nodes, and they are enlarged, or they are one of the first things to get enlarged in gastric carcinoma. They reach here by traveling via the thoracic duct, which you shall study in thorax. But this sign of the enlargement of the left supraclavicular lymph nodes is known as Troisier's sign, MCQ. Okay? Now, vagotomy is essentially cutting the branches of the vagus nerve, and it can be divided into truncal vagotomy, selective vagotomy, and highly selective vagotomy. As we go from above, below in these subsections, we are getting more and more selective. Okay, so the best one would obviously be the HSV, or the highly selective vagotomy. Why? Because if you're going to cut the vagus, you also are going to compromise the gastric emptying. Remember, the vagus is propagating peristalsis. So if the vagal activity is inhibited, you are going to delay the gastric emptying, and you don't want to do that because things got to be normal. Whatever you eat needs to go ahead, needs to be propelled forwards. So highly selective vagotomy could just cut off the branches that are supplying the parietal cells. Thus the acid secretion is reduced without causing any abnormality in the gastric motility and the peristalsis. Okay, spend some time with that, read more about it. Peptic ulcer, more of a physiology thing. It's basically an imbalance between the acid secretion and the protective mechanisms that prevent the stomach mucosa from getting auto-digested by too much acid. So read about that more in physiology, very important. Finally, the referred pain of the stomach, which is a vague pain in the epigastric region because the stomach is supplied by the T6 to T10 spinal segments, which also are supplying the epigastric region. Okay, thank you so much for listening, and you need to spend some more time because this is an important one, the stomach. I'll see you in the next one, which is the duodenum. Bye.